This program is brought to you by Emory University.
All right, good morning, everybody. So I was tasked today to speak about mitral valve disease. I have no disclosures whatsoever. So some primary learning objectives for us today. Mitral valve disease is a pretty big topic. It's kind of hard to completely do everything in an hour, but a couple of the key points I think we should probably be able to get out from today would be to make sure that we review mitral regurgitation evaluation and management. We've got to understand the clinical differences between primary and secondary mitral regurgitation, and as well we'll discuss key features for the clinical management of mitral stenosis. Some topics that we're not going to get to today would include things like congenital mitral valve disease or Schoen complex. Sorry, Anita, we just don't have time to go over details of these types of things. Infectious endocarditis, you should probably have I know that you kind of have like a valve block or something, so hopefully some of these topics have been brought up in other lectures. So infectious endocarditis is kind of a talk on itself, as is prosthetic valves. Pregnancy and mitral valve disease, again, kind of going to be not part of the main topic today. And as for the interventionalists in the room, we're not going to really have time to go over the novel transcatheter mitral valve techniques. However, I would refer you to the JACC from the beginning of this month. There was actually a couple nice articles in there about some of the newer mitral valve replacement and repair techniques and some good editorials in there. So if that's your thing, you can read that article. So I tried to make this a little bit more interactive. So I have a little prizes for the fellows that can get this. So I was just going to go into kind of like a Jeopardy fashion where I'm just going to read the question with the answer choices, and the first one, gets a little treat. Okay, so here's our first question. The mitral valve is closest in shape to which junk food? Is it a Chips Ahoy cookie, a Doritos, Kit Kat bar, a Pringles chip, or a Tostitos scoop? You can just shout it out. There we go, give it a good rush. Okay, so that's right. Pringles. So that's like a very high level. So I have as treats the best that the VA Cantina treats. So I'm just gonna grab in here and we're just gonna see what you get. Okay. So some junk food, some Oreo cookies. Yes. For you. So good job. So we got some treats there. So so that's right. So a Pringles chip. So you can see on the top here, there's a zoomed in photo of a Pringles chip. I did not take that myself. That was from the internet, as well as a schematic of a mitral valve. And as you can see, the attachments, anterior, posterior, are kind of higher up than the medial and lateral sides. Does anybody know? This is just as a little aside. No candy associated with this. The name of that shape of what a Pringles chip, is shaped at. Anybody good at math? What's that? Yeah, it's a hyperbolic paraboloid. So the reason I'm talking about the shape is because the shape is kind of actually preserved through a lot of mammalian species. It's designed to relieve stress on the mitral valve. The mitral valve is under a lot of stress because of the difference between trying to withstand left ventricular systolic pressures. So it has to be able to not break, and so the Pringles chip is shaped like that so the chip doesn't break in the can. A couple anatomy lessons that you kind of already know. I mean, you probably are well aware of this, but besides the fact that it's saddle-shaped, is that it's dynamic. So the mitral valve is attached to the mitral valve annulus, which is attached to chordae, to the papillary muscles, to the left ventricle. The annulus is part of the left atrium as well, and all those pieces have to function together for the mitral valve to work. And if you have problems in any of those components, you're going to have a problem with your mitral valve. During systole, the planimetry, like the surface area of the mitral valve, decreases by up to 24%. So it's a pretty dynamic structure, and thus we have to take that into account when we are evaluating our mitral valve. So mitral valve disease is pretty common. It increases with age. So you can see data here on the top is data from pooled cohort studies of the NHLBI, and the bottom data is from Olmsted County. I'm colorblind, so I have no idea what color these are, but I think this is green. the mitral valve. And so it's about, as you get older with age, it's about 10% of people will have some level of mitral valve disease. So it does increase with age. It's becoming more common to have surgery for mitral valve disease. There's approximately 40,000 surgeries in the US, which is up over the last 6 to 7 years. And mitral regurgitation is common. So in the Framingham cohort study, almost 80% of people in that cohort had some level of mitral valve disease reported, mostly MR. And so we need to know how to address it, because you will see it on your boards and take care of a lot of patients with mitral valves problems. Mitral valve disease, this is the most recent data I could really find to try to illustrate the point that it's somewhat on the rise. These are discharge diagnoses over time, and you can see the increasing rise in valvular disease, and specifically mitral valve disease. This is probably a combination of older age of the population as we get older, and we have more mitral valve disease, as well as that everybody gets an echocardiogram, and so there's probably a lot more recognition of the mitral valve problem. So we're going to first start talking and focusing on mitral regurgitation. So it's the most commonly encountered clinically significant valvular disease you'll see. And when we think about mitral regurgitation, we have to both think about its etiology and its severity. So we have to categorize this: is this a primary mitral valve problem, or is this a secondary problem? Because the management and treatments are different between the two. And then we have to decide, like, is this something I got to do about, something more about? Like, is it moderate to severe, or is it just a mild and trace in severity? Here I list for you the common etiologies for both primary and secondary mitral regurgitation. The ones in bold are the most common that you will see. So for primary disease, obviously mitral valve prolapse or myxomatous disease is the most common reason we have primary mitral regurgitation, followed by endocarditis and rheumatic disease, and mitral annular calcification. Because you are going to be top-notch cardiologists, you should still know the ones that are not in bold as part of your differential of why somebody might have it. So connective tissue diseases, congenital problems, radiation, and you can read the rest of this list. Secondary causes obviously are from cardiomyopathy conditions, dilated or ischemic coronary disease, and although less common, we'd still see plenty of hypertrophic cardiomyopathy people with mitral regurgitation. So you want to try to figure out the etiology so that we know what to do with it. I'm going to remind you guys, or tell you guys, in case you didn't know, there are these days stages of valvular disease. I have not seen this picked up clinically very often. Like when we talk about it, we don't say, oh, this patient has stage C2 mitral regurgitation. Like, it's very uncommon for us to talk about it, but it is in the guidelines since 2014, where they tried to create a template similar to heart failure of valve diseases. So there's 4 stages, just like in heart failure, A, B, C, D. And part of this was for us to kind of link the management of the valve disease to the stage, and to understand that maybe we don't have to focus on end-stage disease. So for a long time, the only treatment was like as a big surgery, but now that we're kind of intervening earlier, we have less invasive techniques. We're thinking about diseases at earlier stages of disease. So, I list here kind of for any valve disease, kind of the description for each stage. And I also want to highlight about the stages. I think it does a nice job that if you read that in the guidelines, when you think about valve disease, you want to think of it like comprehensively as far as its anatomy, its hemodynamics, the consequences of the valve disease, and the symptoms. So all those factors go together to put somebody into a stage of valve disease. So let's just review briefly the pathophysiology of mitral regurgitation, or why we care. So there's a cartoon here for us to review. So this is a normal situation with normal end diastolic and systolic volumes. This patient would have a normal ejection fraction, and they didn't have any regurgitation, and all the blood flow, the total stroke volume was the same as the forward. It all goes through the outflow tract, and the filling pressures are normal. So what happens when we develop regurgitant lesion? So here you can see now we have forward stroke volume and regurgitant stroke volume in equal amounts. And so to compensate for the increased volume, the ventricle has to dilate to decrease the wall stress. So in this situation now we have elevated diastolic volumes with an ejection fraction of over 70%, mildly elevated filling pressure. So this is a compensated kind of severe mitral regurgitation scenario. But over time, that compensation leads to fibrosis, scarring, dysfunction, myocyte death, and eventually the ventricle will not contract very well anymore. So when you have, so here's an example of the decompensated ventricle where now our ejection fraction is falling, we can't squeeze out as much, the filling pressures are getting elevated, and we are trying to avoid this stage. So we need to kind of figure out when somebody's at risk of developing this decompensated state and intervene before it happens. Symptoms are important as a marker of bad prognosis, so we need to get thorough histories in our patients with mitral regurgitation. Most series of people with MR, the symptoms related to bad prognosis, either after surgery or events if you didn't get surgery. However, most of our patients we ask with mitral regurgitation can be frequently asymptomatic. They, are picked up that they have the disease because we heard something on the exam or they got an echo for another reason. So we need to get detailed histories on our patients about this. Usually there might be non-specific symptoms. It might come on slowly, so they may not even realize that they're having decreased exercise tolerance or dyspnea or fatigue. They'll just say, I'm fine. However, questions like, what is the most activity you do in the day, to try to elicit some objective details about what their functional status can be helpful. If you can't discern if they're symptomatic or not, you can consider exercise stress testing. So I just made a little 2x2 table here to kind of think about what would be the role if you're thinking about stress testing and your patient with mitral regurgitation. So if you're severe disease and you're not sure about their symptoms and they think they're asymptomatic, you can offer them preferably a stress echo to kind of really discern if they're really asymptomatic or not. If they don't have severe disease, but they're complaining to you about symptoms that you think maybe I'm missing severe disease because of the dynamic nature of mitral regurgitation, that's another reason you might consider a stress echo. About a third of patients will have worsening of their mitral regurgitation with with stress testing. So a fair amount of people might look just moderate at rest, but actually have severe disease when you stress them. It's a little bit hard to do stress echoes for mitral valve disease if you're using a treadmill because you have to be really quick with that. A lot of the studies really evaluate people with either a semi-supine or upright bicycle where they're stationary, where you're able to get better echo data. So speaking about echo, we don't really have a ton of time to go about the details of the echocardiography evaluation of mitral regurgitation. But I did want to make sure that we highlight the points of the echo reports when you guys do read your echoes or read somebody else's echo, what you want to take away from that when you're dealing with mitral regurgitation. So obviously you have a severity distinction, the etiology. So I frequently will put in my reports they'll have severe ischemic mitral regurgitation or myxomatous mitral valve disease with severe regurgitation. Some type of etiology in the report is what I would recommend. Morphology of the leaflets, are they thick? Are they perforated? Is there vegetation? Systolic function, these are factors that go into our decision making, so you definitely want to comment about systolic function. The size, specifically end systolic diameters for mitral regurgitation. Pulmonary pressures are important. So people with high pulmonary pressures in mitral regurgitation do worse. So pulmonary pressures above 50 or 60 with exercise are key findings that you want to put in the summary of your report when you're thinking comprehensively about mitral regurgitation. I also will frequently put something about the rhythm. So I'll say the patient's in sinus rhythm or the patient's in AFib, because again, those are cut points and thoughts about people's disease process. And then obviously because of the dynamic nature of mitral regurgitation, we also want to always have the blood pressure and the heart rate for us to interpret mitral valve disease and put it in context. So here's our next question for Candy. Which of the following echocardiographic features is least consistent with severe MR? A regurgitation fraction of 50%, an effective regurgitant orifice of 0.3 centimeters in secondary MR, a flail leaflet, a vena contracta above 0.8, E-wave dominance with a peak velocity of above 1.5, holosystolic regurg, or a pulmonary systolic pressure above 60 with exercise. What do you guys think? What was it? B. There you go. All right, Candy, Salim. I could just throw it to you. There you go. All right, good job. So this question's a little, this isn't a question you're going to per se necessarily see on your boards, but I wanted to use it to highlight kind of a couple of points. One is to go over some of the criteria of what is severe MR when you're evaluating by echo. So traditionally the regurgitative fraction is how we decide something is severe. So if it's 50%, the regurgitative fraction, that is severe MR. I don't see a lot of people necessarily always calculating that. There's some a lot of technical issues about calculating that sometimes, but that is what we use. A flail leaflet is very specific for severe mitral regurgitation. So if you see a flail leaflet, it's almost always severe MR. Vena contracta is above 0.7. Remember, is a severe MR, is consistent with severe MR. E-wave dominance. So this is an indirect measure. So when you try to interpret and integrate your echoes for mitral regurgitation, you want to not only focus on some of those quantitative measures, but some of the indirect findings you will see. So if you have a very high inflow velocity with an E wave of above 1.5, that would be consistent with severe MR. If you have like an E to A pattern with a very small E and a very big A, it's unlikely to be severe MR. Holosystolic regurgitation, that's in the question to think about, that you can have MR that looks very severe by echo, but it might be like mitral valve prolapse, which is only like half of the cycle. So if you only have a severe looking mitral regurgitation that's only half of your cycle, then the total regurgitant volume and fraction is actually not in the severe range. So your ERO might be high, but your entire regurgitant fraction and volume is not in the severe range. So holosystolic regurgitation would be more consistent if you had severe MR. And then we mentioned earlier that pulmonary systolic pressures, again, are kind of an indirect consequence of having severe MR over time. I put the answer as B to highlight like what, so getting back to the correct answer, like why is it B? So we know that quantitative measures of an effective regurgitant orifice area of greater than 0.4 are consistent with severe MR. However, when the original 2014 guidelines of the valves came out, they talked about that secondary MR, the ERO is prognostically worse at 0.2. Okay, so there used to be a cutoff that we said, well, if it's 0.2 in secondary MR, that is severe secondary mitral regurgitation. And the reason being is like anytime we try to focus on what is severe, what does it mean to be severe valve disease, it's usually because we know that prognostically people don't do well. So they said, in secondary MR, if your ERO was greater than 0.2, people had much worse outcomes. So that should be considered severe MR. However, I think this caused a lot of confusion, and then a focused update in this last year, they went back and said, okay, that was too confusing, so we'll go back to 0.4. 0.2 is more sensitive as a measure, but 0.4 is more specific. But the reason I wanted to also highlight this was because the ERO assumes a circular geometry, and a lot of times the regurgitation in secondary MR is more of a crescent shape, through the entire mitral valve. So the ERO definitely underestimates the amount of regurgitant volume and fraction you might have, similarly compared to primary MR. So just a couple tidbits about echo to try to take away. So how do we manage mitral regurgitation? So we said it's very common if you have trace or mild disease and you don't have any other significant problems, symptoms, valve problems, other valve problems, or ventricular abnormalities, we don't really need to do anything up. You can reassure the patient, they're like, why is this on my echo report? You're like, don't worry, it's very common, we don't have to do anything more about this. But if we have moderate to severe disease, we have to think, is there any medical therapy I need for our patient? Do we have an indication to go to surgery for this patient? And if we don't, how often do I have to kind of recheck them? So this will all depend on our symptom severity and etiology. So medical therapy is pretty limited. In acute mitral regurgitation, there are some medical interventions that we might need to do. There's no opportunity in this situation for remodeling of the LV, so people become very symptomatic. They're usually in distress. They could be in shock, acute pulmonary edema. This most commonly happens in the etiologies such as ischemia, like around the time of an infarct, endocarditis, or a flail leaflet with myxomatous disease. You have to be aware that you may not hear a murmur in this situation because the MR could be more wide open. So you have to have a high index of suspicion in these clinical circumstances for the MR. The treatment is generally stabilization with afterload and preload reduction, nitroprusside, diuretics if you can. If they're in shock, then putting them on inotropes with an intravenous balloon pump could be helpful to bridge them to either stabilize them or get them to a surgery. In chronic disease, we really don't have anything that's been shown to alter the disease course. So there have been studies on afterload reduction, calcium channel blockers, ACE inhibitors. It doesn't really seem to matter. We generally defer that if they have hypertension, well, we'll treat their hypertension according to whatever guideline is out that day, and we just use our typical meds. Finally, we talk about exercise restrictions, sometimes with people with valvular disease and heart problems. But if you have asymptomatic severe mitral valve disease, you can still exercise as long as you don't have bad pulmonary hypertension and a normal left ventricle. So who do we decide to send to surgery for primary mitral regurgitation? So you first got to start with they have to have severe mitral regurgitation, all right? So severe disease, if they have symptoms, they're stage D, you refer them for surgery, preferably with mitral valve repair. But if they don't have symptoms, but they have LV dysfunction as defined as an EF between 30 to 60%, not 55, but 60%, or an end systolic diameter greater than or equal to 4 centimeters, that's a class 1 indication that these patients are starting to remodel, starting to have LV dysfunction. They need to go to surgery because they're going to be associated with worse outcomes if we wait any longer. So even if you don't have symptoms, you don't have the LV dysfunction, but you're at a place where you feel like your surgeon is highly likely to be able to repair that valve, and they're a very low-risk patient, then that is a 2A indication that if you could repair that valve, you could refer them to surgery. And if they're asymptomatic and they feel great, you could tell them, like, I recommend that we just fix this valve. So there was a recent new update or tweak to the guidelines that says, look, if you don't have symptoms, you don't have LV dysfunction, you're not even sure that your surgeon can completely fix that valve, but you have progression of LV changes, such as like your EFs dropping, maybe it's not less than 60%, but it went from 70 to 65 and your diameters are getting bigger. Well, now that's a 2A indication that you can as well refer them for mitral valve surgery. If you don't have any of these indications and you decide to watchfully wait for them, then we would surveil them every 6 months. This is important to know. These are the questions that kind of get asked on your tests. So timing of surgery. So there's kind of two schools of thought. Should we go for an early surgery, like if we're in the asymptomatic stage, or can we watchfully wait with them and just wait for a more firmer indication for surgery? So on the left here is data, a little bit more recent data, looking at patients that had flail leaflets from a multi-center registry, and they looked at their patients and said, people that went for early surgery, like within the first 3 months, when we propensity matched them to people that did not go for surgery and were medically managed under a watchful waiting strategy, they did worse. And so this is like the most compelling data we have of why early intervention, would be helpful. Now, this is not a randomized control trial. I think it's still going to be limited by confounding. I believe that's actually most of that. But they did they did as good of a job, I think, as you can with anything that's not a randomized control trial to try to answer this question. On the other side of the watchful waiting camp, this is data from a single center in Austria, now a few years old, but they prospectively followed their patients and said, look, I'm only going to take you unless you have like a real firm indication of needing surgery. And you could see here like the rates of events, like either they develop symptoms or asymptomatic LV dysfunction or AFib with pulmonary hypertension. And you could see collectively over about an 8-year course, less than half of the people ended up developing one of those indications. So the thought was, look, if you have a patient that's like feeling fine, they're like, I'm riding my bike, I don't know, doc, why do I have to have a big open heart surgery? It can be kind of hard to convince those patients to do something if they don't feel bad. So they would argue, and I do believe this, that you can safely watch them as long as you're in a good place where you feel reliable about your echoes. You're watching them every 6 months. You don't want them lost to follow-up. Then it's a reasonable strategy to undertake. However, more and more, I think the impetus is like to find valve centers of excellence and try to get people to early surgery and just fix it instead of trying to wait for a problem to happen. This is a little bit more recent data, again, arguing for maybe earlier surgery. This was a multi-center data from 4 different sites in Europe looking at almost 400 people with a mean follow-up of 3.9 years. And they looked at what the event rates were for people over time from a flail leaflet that did not undergo surgery. And on the bottom here, collectively, you saw that 15% of the cohort had some sort of event, and when they linearized the rates to annual rates, you could see about the annual rate of something bad, AFib, heart failure, or even death. The rate was about 12% per year, so after about 5 years, half of your patients are going to have some event, and some of those events are going to be death. So there is a small risk of sudden death in patients with severe MR and flail leaflets, so there might be an argument like, well, you don't want to wait around for something bad to happen because you might not have an opportunity to fix it later.
Were those patients who otherwise could have gotten surgery, or were they not getting surgery?
That's not clear. So valve disease is kind of like, we got to grade our evidence on a curve compared to the rest of cardiology, I think, because there's not as many, it's not like coronary disease and heart failure. There's very few large randomized trials. Most of the data we get is from expert opinion, people that have had a lot of experience with valve disease, as well as just a lot of surgical series. So, a couple centers will go and they'll look at their surgery series retrospectively and see what people did bad, what people did good. There's not as many randomized trials, except now we are starting to get into an era with, I think, the transcatheter techniques where we are getting more and more reliable data. Like, just as an aside, like, it was very reassuring in the partner data to see that, hey, you know what, fixing aortic stenosis, like, we always thought that, like, we knew AS was bad, people would die, fixing it would make people better. But we actually never kind of actually knew that from, like, a randomized trial. And then we did partner, and that was, like, kind of confirmed that, yeah, this therapy, if we intervene, will save lives. So we don't necessarily have that similar data in mitral valve disease, but I assume one day we will have that. So when we think about surgery, mitral valve repair is always the goal. Okay, so this is data, this is administrative data from Medicare beneficiaries, and these authors looked at people that went under mitral valve repairs, people that went under mitral valve replacements, and the expected life expectancy of similar aged patients. And you could see that patients that underwent mitral valve repair had a basically identical life expectancy as people without mitral valve diseases. Unlike the mitral valve replacement, those that undergo replacement have a significantly worse survival outcome. Again, this is confounded, it's administrative data, but it does say that if you find the right patients that can go undergo mitral valve repair, they can do very, very well. All right, next question. Which of the following best classifies the following images? So your choices are a combination of it's highly repairable or unlikely repairable, a Carpentier classification of 1, 2, or 3, and is it Barlow's disease or a fibroelastic deficiency. So there's A, B, C, D, E, and multiple combinations. What do you guys think or know? Does anybody even know these terms? I'll give you an opportunity to look at them. You guys want that candy. There's no harm for guessing. We're not going to judge you. Oh, we're going to judge you. What did I hear? Wrong. B, good. Answer is B. It's unlikely repairable. It's a Carpentier motion. It's Barlow's disease. Who said that?
Over.
I should have disqualified him because I did go over that with him like earlier in the month. But I like Omer. There you go. Oh, sorry. All right. So, so I should have disqualified Kieran and Omer. We did talk about this a few weeks back about what these are. So this question is really trying to get at, what are repairable features? So like when you do an echo or you like evaluate your patients and you're like, well, is this thing going to be repaired and I should refer them early, or is it unlikely? We need to know what those are. So we'll go back to that picture in a second. But here I list things that are favorable anatomy and clinical issues with a repair versus those that are unfavorable. So favorable conditions would be things that are in the posterior leaflet or isolated P2 prolapse. That's an easier repair. If you have excess tissue, the surgeons like tissue. They can cut away tissue, but if you don't have tissue because it's destroyed, well, that's a harder thing for them to deal with. So excessive tissue is favorable to a point. If your subvalvular apparatus is normal in character, then that's favorable, versus if it's thickened or calcified or retracted, that's harder for them to fix. Calcification is not the surgeon's friend, so if you have no calcification, that's a good thing. Bad calcification, that's not going to be repairable. And then the Carpentier. So below I show you this Carpentier classification. This surgeons care about motion of the leaflets, and that's why they created this classification. So type 1 classification for them is normal leaflet motion. So that would be in situations where you had like endocarditis, a perforated leaflet, just a dilated annulus. If the leaflet motion is normal, type 1, that's a repairable characteristic. Type 2 is mitral valve prolapse. So when you have excessive motion of the mitral valve leaflet, that is easier for them to deal with. So that's a little bit more favorable. They can fix mitral valve prolapse. But if you have a restricted leaflet motion because of rheumatic disease or because of ischemia, that's much harder for them to correct. So in this question with this motion, you could see in the echo, if I get it to play again, clearly mitral valve prolapse. It's bi-leaflet, right? And let's see if this will play again. We'll see. Maybe it'll take a second to load up. But it's a Carpentier type 2. It's unlikely repairable because of the bi-leaflet disease. And when I say Barlow's or fibroelastic disease, these might be terms you might hear. The surgeons use them. It's really a classification of like when they do surgery, they look at the valve and it has some type of gross characteristic. Sometimes it looks like this myxoid, diffuse thickening, similar to what this appearance on echo, which I don't know why it's not playing anymore, feature is, versus a fibroelastic deficiency, which is translucent. It's usually an isolated. It's seen in older people. That's usually sometimes like that isolated P2 prolapse that's able for them to fix a lot easier. They've done studies where the surgeons look at these types of gross characteristic changes in the valve and they sent them for histology, and there are kind of just some fundamental changes between the elastin content or the myxoid contents of those valves. So there is some pathophysiologic differences in people that, in myxomatous disease that aren't really well known or characterized. But this is kind of like a typical, what we'd say, a Barlow looking valve, very billowing, diffusely involved, younger patient. This is a little bit harder to fix. All right. Next question. Which of the following features is most important to be considered a referral center at a mitral valve center of excellence? Is it A, you need a catchy logo, like we're all in this together? Do you B, the ability to perform minimally invasive robotic surgery? C, be a clinical trial site for percutaneous mitral valve replacement? D, you report your outcomes to the Society of Thoracic Surgery? Or E, surgeons perform at least 25 mitral operations per year? E, who said that first? I think it was Alex. He's my fellow. There you go. So E, don't need catchy logo and a cool advertisement does not make you a mitral valve center of excellence. What you need are surgeons that do a lot of surgery, specifically mitral valve surgery. So, like I said before, one of the indications to go for early surgery was, are you going to have a likelihood of good repair, and are you not going to die, right? So those are kind of characteristics, but it's very hard for us to know, that, from a center if you're going to refer them. So what they show is, if you want greater than 95% and less than 1% mortality, there's very few places that will actually achieve that. To the right is data from a recent study looking at the STS of people that underwent mitral surgery for MR. You can see the median mortality was 3%, not 1%. Similarly, morbidity was high at 17%, and the overall repair rate was only 75%. So by and large, your average center is not going to be able to achieve the repairs that you think you're going to have. Now, this is, again, somewhat administrative observational reporting data. There are, a lot of series from a lot of institutions, Cleveland Clinic, Mayo, the surgeons there, and they show their rates, and they're like, look, I get almost 100% repair rates in patients that I say I can do it on, and they do very, very well. So that's where a lot of the data comes from. So if you could find surgeons that are very well trained, that do a lot of mitral valve surgery, those are the places that, are more likely to come out with a repair. So some data has shown that you need at least about 25 surgeries a year. So the more you do, the better you are. Some of the data really showed that if you did more than 40 mitral valve surgeries, then you're much more likely. But the bare minimum we want is about 25. If they've had specialized training in mitral valve surgery, so they've worked with people that have done a lot of mitral valve surgery, that would be helpful. The type of incision, so some data about that. There are more and more surgeons. They're trying to drum up more business. They kind of want to be able to do a lot of things, and so they're trying to look for minimally invasive, like say, surgery's not that bad. I don't have to, crack your sternum open anymore. I can fix you pretty reliably without that. But that doing an incision that's not a main sternotomy, like a thoracotomy or robotic surgery, hasn't really related to any better outcomes for people. It does show that you have less cosmesis. So if you have a young person that wants to get back into a bathing suit, that might be an important feature for them, but it doesn't really translate to actually clinically meaningful outcomes. And actually, a lot of those incisions are more painful than an actual sternotomy. Finally, if you do take care of, the most common thing you see is posterior P2 prolapse. If you have that situation, if your surgeon cannot repair that lesion, you better find another surgeon, because that is the easiest repair for a surgeon to be able to accomplish. And so if they're not giving you mitral valve repairs, send them somewhere else. All right. If we don't have patients that need surgery, how often do we need to follow them? So if you have severe MR, every 6 months, you got to get a history, physical, and an echo. Make sure they don't have a firmer criteria of why they need surgery. You could consider, again, exercise testing them if you're unsure about their symptom status. If they have moderate MR, you should do it at least once a year. If moderate is kind of like a broad term. Like we know, like when we are like, oh, that's definitely severe, and we have the category, well, that's definitely mild, and then we're like somewhere in between that's moderate. But there's moderate that's closer to severe, and there's moderate that's closer to mild. So if people are stable and they're closer to the mild side or not near severe, I would go to the higher end of the range and just see them every couple years. I do think that it's important that you talk with your patients that have like especially myxomatous disease or any of those mitral valve conditions that they can suddenly worsen quickly over time. So they might be feeling great and all of a sudden they snap a few cords and now they feel terrible. So they need to recognize that those things, I usually give like a parachute analogy, like if they snapped cords, that could severely worsen very quickly. So if they have those symptoms, they got to get treatment and they got to let you know as soon as possible. And you reevaluate them again with any change in their symptoms. All right, transitioning quickly here to secondary mitral regurgitation. So unlike primary MR, secondary mitral regurgitation is a ventricular problem. It's not a mitral valve leaflet problem. Treatment is at the cardiomyopathy, is to treat the underlying cardiomyopathy. It is not the mitral valve in itself. Treatment of the valve does not necessarily improve their prognosis because it's dictated by their cardiomyopathy. There have been a couple recent surgical trials about secondary MR. This is one from the New England Journal. They came out, I think they were published in the same edition. About 300 patients that were undergoing CABG, and they got randomized. They all had moderate MR. They got randomized to mitral valve repair with the CABG or just CABG alone. And you could see on these Kaplan-Meier spiral curves, there was really no difference in outcomes over 2 years. There was less MR in the mitral repair group because they fixed the valve. But even people that did not get fixed still had less MR when they came out after just revascularization alone, but not as much as if you fixed the valve. But regardless of fixing the valve, they didn't change their outcomes. And as a matter of fact, they had more neurological, postoperative neurological events and supraventricular arrhythmias. So the extra pump time, cutting into the atrium, these have not been shown to be helpful just to correct moderate MR. Here's a series of 250 patients that were randomized that had severe ischemic MR, and they got randomized to replacement or repair. And again, replacement or repair did not have any change in major adverse cardiovascular outcomes after 2 years. Moreover, they had higher rates of recurrent MR in the mitral valve repair group. So remember, like things that are favorable for repair, well, ischemic or mitral regurgitation is not favorable for repair. And this shows that after 2 years, about over 50% of patients had recurrent significant MR after 2 years. So a lot of death in secondary ischemic MR here, as well as recurrent MR. So repair, not better than replacement. So there was some updates to the recommendations of like what should we do in mitral valve surgery and secondary MR. So if we correct severe MR at the time of CABG or an AVR, if you're going in there and they have severe MR, it's still a 2A recommendation, even though we don't have great data that it's still going to affect outcomes. But mitral valve replacement is now somewhat favored over doing a repair because of the high recurrence rates in secondary MR. If you just have severe secondary MR and refractory heart failure symptoms, despite all your medical therapy and CRTs and stuff like that, it's only a 2B recommendation. We really don't know that surgery in those situations is going to make people better or make them live longer. So it's kind of left as like, well, we don't really know. It seems like maybe it should help, but you have to really have a really good surgeon, a good team kind of evaluating those situations about whether or not we should send them for surgery. And mitral repair for moderate MR at the time of CABG is now, it was always a 2B, but now it's been downgraded as far as the level of evidence. We really don't think that, in the short term, that's going to improve people. It would be great if we didn't have to send people to surgery and we had a less invasive therapy for that situation. So that's kind of where the hope of transcatheter techniques might one day come into play, because surgery in those patients are always very high risk. So if we had less invasive therapies, that would possibly go a long way. However, here I list the indications of what commercially to do a MitraClip, what you should have. So it was approved 4 years ago, but it's really limited to people that are prohibitive risk for surgery, so they can't undergo surgery. They have primary degenerative MR, anatomy constraints, and they're part of like a heart team and center. Here's just a kind of clip of, you guys are probably somewhat familiar with the clip. So here's somebody with MR. They get a clip. Look, they don't have an MR anymore. Wow. So this is what it looks like. You put the clip in. You have this double barrel orifice. This is a 3D shot looking down at the LV of like what that looks like. So the mitral clip is inferior to mitral valve surgery. That was shown in the Everest trial. We do have 2-year data now, or not 2 years, 5-year data from the Everest trial. And so even though the proponents of mitral clip would say, okay, look, we know that surgery is better in that population in the randomized control trial, but look, people that still got the mitral clip, you can see the people in the device for surgery arm after 5 years, people that got the device still had less MR than they did at baseline. So it's effective. It's relatively safe. The heart failure symptom classification improved in a lot of these patients, even if they got the device anyway. So yes, is surgery better? Sure, but if you can't get surgery or you're too high risk, maybe the mitral clip is a good situation. Now, most of the people in the Everest trial were for primary MR. There was some secondary. The reason that the FDA approved it for prohibitive risk was because the trial people realized that, a lot of people weren't getting into the trial, but they didn't have other good options, and they created this like high-risk registry, and they showed in that registry that people, even if they didn't have the anatomical constraints of the trial or were a perfect candidate for the trial, that we could still effectively reduce their MR and make their symptoms better, so it's approved in that condition. It is, however, used in secondary MR a lot in Europe. So Europeans always do things before we do. The bottom here is data showing in a small study from Europe of like 50 patients. This is as good as the data we have in secondary MR. Now look, you can have people that went for CRT. So before CRT, they still had a lot of heart failure and a lot of MR. They got CRT. These were non-responders. They didn't improve. But then they went for a mitral clip. And look, after a year of mitral clip, their symptoms improved and their MR all got better. So you'll see a lot of this for secondary MR based on these smaller observational series that mitral clip might be adequate for them. But we don't actually have any good data with a control group or on firm clinical outcomes like major adverse cardiovascular events that actually fixing MR and secondary MR is actually going to improve. So currently, it's not approved that. There's ongoing trials for us to finally answer this question. There's like a COAP trial, which I feel has been recruiting since I've been in med school. But it's still out there, and maybe one day we'll have those results. Here's the most important question of the day, and I know the answer because I was here early. Which non-chief fellow, sorry you guys got excluded because I thought you guys would be here potentially very early, was the first fellow to come to lecture today and is still here for the talk? Who wants to own it? No, it was not you, Mohammed. Yes, it was Dr. Mirza. He's shy, but he was here first. So he wins the grand prize of the day. Congratulations, Dr. Mirza. You win a brand new, what is this, 5th edition Practice of Clinical Echocardiography book. This book is valued at $200 on Amazon. I do not want you to sell it. I want you to read it and use it and share your knowledge with others. But congratulations. It pays to get here on time, early, for my lectures. Show initiative. Good things happen. Congratulations. Yay, Omar. Get here on time. Woo! All right. You won 2 prizes. You're now excluded from any other prize. All right. So miscellaneous mitral valve disease, show and tell section. All right. What is this abnormality? Who's the first one to figure this one out? I heard it. Own it. Cleft mitral valve from the budding congenital doctor, yes. It's cleft mitral valve. Congratulations. You get candy. Yay. I don't want to hit anybody. All right, so I don't know why this plays and then stop playing, but let's see if we can. Oh, I think like my computer is like stalling or something. All right, well, cleft mitral valve. So this cleft here is a picture of it. You can see here in the anterior leaflet kind of this echolucency gap here. That's a cleft mitral valve. It's kind of anteriorly, it's usually associated with endocardial cushion defects. Posteriorly, it could be an isolated finding associated with MR. So just something to be aware of. All right, next question. Let's see. What is this abnormality? I'll give it to you. Okay, yes. So caseous mitral annular calcification. So it's a MAC. All right, nice job. Oh man, that was not good. You all right? It made it to your hands. All right, so caseous mitral annular calcification. So this is, again, mitral annular calcification. This is just kind of like a variant of that, where it's like very protuberant. Calcification, there's kind of like a Swiss cheesing, like holes in the calcification. You can see this in older age people with advanced kidney disease. It's associated with atherosclerotic risk factors. On rare occasions, it can lead to mitral valve stenosis. Surgery is very difficult in these situations because the calcification, again, is not surgeon's friends. That can embolize, or they can, like, if they're trying to cut out and debulk that calcification, they can disrupt the AV annulus, and that's pretty much almost always fatal. I will make a little comment here that mitral annular calcification, not necessarily the caseating, like protuberant form, but regular MAC is very common. I'll see a lot of fellows, always comment, oh, well, there's not stenosis, or, the valve leaflets look terrible. But a lot of that is actually just shadowing of the annular calcification. The leaflets are frequently just fine. It's very uncommon to actually have stenosis. You might be like, well, I saw two people like here at the university that needed a mitral valve replacement because of that. But it's by and large very uncommon that the MAC will have to lead to some type of surgery or severe stenosis. All right, next one. What is this abnormality? Salim's like, I am not answering. I know what that is, but I am not saying because I do not want candy thrown at me. I will hand you the candy. You do not have to get it beamed at your head. Anybody have an idea? Who said that? Oh, Dr. Condado. There's hope for you yet. All right, so this is a non-bacterial thrombotic endocarditis or Lehmann-Sachs endocarditis. So description of these, these kind of verrucous lesions less than 1 centimeter. They're frequently at coaptation points on the atrial side. They're associated with thickened leaflets. Here's a 3D view of what it would look like. They're associated with, NBTE is associated with malignancy, so people with malignancy, or in autoimmune conditions, they're usually thrombus and fibrin deposits associated with immune complexes. These have a high embolization risk, more so than just infectious endocarditis. The clinical situation is kind of like, you'll see somebody that you're like, oh, is that endocarditis? And it is, it's just not infectious. It's usually associated with some other clinical condition. But this is kind of like a good example of what that looks like. All right, now come get your starburst.
All right.
Congratulations.
See, I can drive it.
That's right. All right, we're going to finish off here in the next few minutes on mitral stenosis. So it's almost always universally due to rheumatic heart disease. Here is kind of some recent data. This data is funded by the Gates Foundation, showing both the prevalence and the change over time of rates of rheumatic heart disease. You can see, I can't tell what colors these are, but I could see big dots, and the big dots mean more prevalence. And so where is rheumatic heart disease? Well, it's in sub-Saharan Africa and southern Asia. So if you take care of patients, if you have a graded clinic, you certainly, I'm sure many of you have taken care of patients, with rheumatic heart disease, and because it's becoming pretty much, extinct in third world or in Western countries. So when we think about rheumatic disease, we need to think about our evaluation, which surrounds the echocardiogram, and then how do we manage those patients? So we need to think about our prevention of rheumatic fever, management of their symptoms, and then preventing thromboembolic disease. So I hear, sometimes when we get these rheumatic patients, I never really hear anybody talk about this when they're signing out to me, but I think this is one of the things I think about is, are they at risk for recurrent rheumatic fever, and should they be on prophylaxis? So you should think about people, especially when they're young, less than 40, if it's been within 10 years of their last attack, those patients should get daily or indefinite, prophylaxis until they're older or out of risk. Other high-risk conditions include people that have young children because, they carry around streptococcus, they're always sick. Crowded environments. If you have very severe valve disease where you think it's going to progress, then you might consider prophylactic people to prevent another recurrent bout of rheumatic fever. The antibiotic regimens to choose from, so it's generally penicillin. It's pretty cheap, it's pretty available, it's oral. You can similarly give them penicillin, but intramuscularly every 4 weeks. I kind of, in the patients that I've taken care of with that, where I was concerned about compliance, I think it's a very effective way to make sure that they're getting their prophylaxis, because they just come in once every 4 weeks, nurse visit, they give them a shot, and it's done. If you have a penicillin allergy, you can use like a macrolide, like clarithromycin. Symptoms, so patients get symptomatic. Main treatment is beta blockers. This will allow us to increase diastolic filling time, diuretics to decrease their congestion, and rhythm control. If they lose their atrial kick against mitral stenosis, they might become symptomatic. We can try rhythm control. It may not be successful because these people have very diseased and enlarged left atrium, but we certainly, I think, is worth trying. The real factor in the decision, similar to mitral regurgitation when we talked about, well, is this valve repairable? In mitral stenosis, we look, is this valve suitable for a mitral commissurotomy, with a balloon? So here are some, when we think about that, we think about the valve morphology. So we have to look at the mobility of the valve leaflets, the calcification, the thickening, the subvalvular thickening. You're all probably somewhat familiar that there's this Wilkins score, looking at those features. I didn't want to go through the entire detail of those. You can look at it in a table, but these are the features that we look at. And so the worse the thickening, the worse the calcification, the worse the mobility, the less likely that's going to be. One of the other features that's not in the Wilkins score, but that is highly associated with poor balloon candidacy would be if you had high commissural involvement with very heavy calcification. If you basically have bicommissural calcifications, it's not going to work with a balloon. You're going to need surgery. Reasons you can't do a balloon, so if you're working somebody up for a balloon mitral commissurotomy, you need a TEE. You need to make sure that they don't have any LA thrombus. You need to make sure they don't have significant MR, because you can worsen that, and then those patients don't do very well. If you have other concomitant heart disease, like other valve diseases, or need CABG, then doing just a mitral balloon alone is not the treatment, it's surgery. The reason that you need to figure out about the candidacy, this is the flow chart from the most recent guidelines, is because the decision about is this valve favorable for a balloon is pretty much in every decision tree. So it's very straightforward when you have severe MS, that's judged by a mitral valve area, preferably by 3D planimetry by echo. So if you have a severe mitral valve area, you're symptomatic, and you have favorable valve morphology, well, that's a no-brainer. You go for a balloon. If you're not favorable and you have symptoms, refractory symptoms like advanced heart failure symptoms, then you can go for surgery. But even if you're asymptomatic and you have categories again, like do you have a balloon? Do you have favorable anatomy? Sure, go for a balloon. Are you asymptomatic but very severe disease, but you're favorable for a balloon? Go for a balloon. Even if you have progressive disease, you're moderate, you don't even have severe MS, but you have symptoms and have high wedge pressures, and you're favorable for balloon, you can go for it. So really, I think when you think about mitral stenosis, look at those criteria, talk with your interventionalist, look for those characteristics, and see if you can have a balloon. Lastly, mitral stenosis, rheumatic disease, is associated with very high rates of thromboembolic disease. So you definitely have to think about anticoagulating your patients. It's a 17-fold increased risk if you have AFib and rheumatic mitral stenosis of strokes. So those patients need anticoagulation. They need Coumadin or warfarin. They do not get NOACs. So, like we sometimes talk about valvular AFib and what is valvular AFib. That's been an evolving definition. But rheumatic mitral stenosis is the literal definition of valvular AFib. Those patients don't just have thrombus frequently in their appendage. You have to, if you're searching for thrombus, you have to look through the entire left atrial complex. They have very large left atrium. They can have thrombus anywhere in there. So if you have AFib with rheumatic disease, you get Coumadin. You had a thromboembolic event, Coumadin. You have LA thrombus, Coumadin. If you have like a big LA and you have a lot of contrast, I strongly suggest Coumadin if they have a low bleeding risk. I do that for patients if they don't have a high risk of bleeding. So you definitely want to do that, and definitely not give them a direct oral anticoagulant. So what's on the horizon for mitral valve disease? So we didn't really have time to go into it, but percutaneous transcatheter techniques are on the horizon. I think there are still lots of hurdles. It's still kind of more of its infancy. It's not as well developed of aortic disease, but hopefully with some good engineering and more efforts, they'll get there. As well as not only replacing the valves, but repair techniques, percutaneous. There's been studies looking at these new neocords or direct annuloplasty of them, using catheter techniques. I believe that the surgeons are going to try to compete. against these transcatheter techniques, and they're going to get their act together, and they're going to kind of consolidate and focus, like who are the really good mitral valve surgeons. So improved mitral valve surgery, less invasive techniques from their standpoint, quality metrics to show that this, that surgery is not that bad or even better than any transcatheter technique will be on the horizon. And finally, I think there's efforts, again, with the Gates Foundation to actually eradicate rheumatic heart disease by being able to get, antibiotics to underdeveloped countries. So I would see that on the horizon for us as well. And that's all I have, with a couple minutes to spare, so I can get to the VA and get parking. Are there any questions? I will stay. All right, thank you guys.
The preceding program is copyrighted by Emory University.